Good evening, everyone. Tonight is Sunday, October 3rd. I'm Deborah Hilbasell, and we're going to do case list reviews tonight. I think I see some new names here that weren't on the September webinar, so let's just briefly go through how to participate. If you look at the upper right-hand side of your screen, there's a little orange arrow, and basically what that orange arrow does, it can open and close your panel in case for some reason it's open and it's blocking some of the screen that you need to see. It looks like almost everybody is using their mic and speaker, so there's nothing that you need to do. But if you did have to phone in, you just click on use telephone and you'll get a phone number, an access code, and a PIN number, and that will allow you to access the webinar. With regards to volunteering, I think you all know how to just click raise your hand if you're volunteering. And then the only other thing is oftentimes when I click on your, if I'm calling on you and I click and I unclick your microphone on my end, oftentimes you have to, you're still muted on your end. So if you go underneath the orange arrow, that little circle with the microphone, just make sure that you're in the blue. I mean, in the green, I'm sorry. Uh, don't know my colors today. All right, so let me close out of here and let me pull up the case lists. So that will be ready. Good, I've got October's case list here. All right. So, boy, our groups keep getting bigger and bigger. So let's see if I can try to, I looked over some of the names who've been called on recently. So I'm trying to maybe get some names who haven't. I don't think Maddie has. Hey, Maddie, you there?
Yes, I'm here.
Hey, Maddie, how are you doing? Happy
Hey,
Sunday.
I'm good, thanks.
Good. So are you a general OBGYN?
Yes.
Alrighty. And have you done any of the case list reviews yet?
I have, I think uh, but not very many because I've often been on call on whenever on the case list review days.
I'm sure. Okay. So do you have a particular case list or even a particular case you want to review?
Maybe starting with OB.
Okay. And do you want me just to pick something random or do you have a case like, will you please ask me on this case?
If you want to ask about one of the maybe 72 is a vacuum delivery.
You bet. Okay, so let me just take a quick peek at this one. Wow, there's a lot of pathology here, isn't it?
Mm-hmm. It was, as you can tell, a complicated, difficult
Case,
case.
right? Yeah, right from the beginning. So let me just
Mm-hmm.
go ahead and do for a couple of questions on just the antepartum care. With
Uh-huh.
regards to marijuana use, we know it's legal in a lot of states. What do you actually counsel your pregnant patients with with regards to marijuana use during pregnancy and or during breastfeeding?
Yeah, so in Oklahoma, where I practice, a lot of women do have their medical card for marijuana, but I advise them that in pregnancy it is not recommended. Um, Even similar to like cigarette smoking, there can be risk of concern for miscarriage, of fetal growth restriction, abruption. Um, and other things specific to marijuana that potentially could affect like baby's brain development, as a lot of unknown risks. I try to determine what their reason for using marijuana is and then try to address, whatever they're maybe treating with marijuana using other medicines or therapy to help with that problem.
Okay. With regards to her right leg amputation, do you know why was her leg amputated?
This was related to a motorcycle accident. and
Okay.
was several years prior to the pregnancy.
Okay. So you're saying during her pregnancy, she developed a superficial venous thrombosis?
No, that was a complication after the amputation, after
Okay.
that injury, which was more than a year before this pregnancy.
Perfect. Gotcha now. All right. So the next thing, class 3 obesity. When someone comes in with class 3 obesity, how do you counsel them about the risks of class 3 obesity in pregnancy?
So I counsel them about weight gain in pregnancy. So we would like them to maintain or have about 10 to 15-pound weight gain. They are at a higher risk of a stillborn, and so I do have them do antenatal testing later in pregnancy, though it's undetermined if that is, effective at decreasing that risk, but we are concerned about that. They are at risk of potentially like growth restriction, or it can sometimes be difficult to follow up on the baby's growth and get accurate fundal heights. So I get growth ultrasounds to monitor the baby's growth during the pregnancy.
Okay, what about maternal risks?
Mm, Because maternal risks could be higher risk for um, like blood pressure, potentially blood pressure complications, hypertension in pregnancy, of blood clots, so DVT, PE, especially in regards to if they needed a cesarean section for delivery, they could be higher risk for a blood clot postpartum. So making sure to have DVT prophylaxis would be important.
Okay, so going back to the class 3 obesity, let me see. I noticed that she was on low dose aspirin. Why was that?
Low dose aspirin given her um, multiple risk factors. So with the superficial venous thrombosis and then the obesity, um, would both make her higher risk for preeclampsia.
Okay, so at 39 and 0, it was decided for multiple reasons to go ahead and get the patient induced. It looks like she developed a category 2 tracing. I don't know if that was state during the first or the second stage. Was this second stage?
Yes, this would have been in the second, or the category 2 tracing um, was in the first stage, but it resolved with intrauterine resuscitation, and then
Okay.
was category 1, and then in the second stage was category 2 again.
Okay, gotcha. And so your decision to do an operative vaginal delivery was based off of what?
The tracing,
Okay,
um,
all right.
due to having the deep decelerations.
Okay. So you tell me how you managed her shoulder dystocia.
So her the head, with the vacuum assistance that we delivered, the head really delivered quickly with that assistance, and then the shoulder did not immediately follow. And knowing that this baby was in distress, I was trying to deliver, of course, as fast as possible. So with concern for a possible shoulder dystocia, she was placed in Mick Roberts position and suprapubic pressure was applied, and then I delivered the posterior arm, and with all those maneuvers the infant then delivered easily after that.
So why did she have 0, 0 of APGARs? I mean, I know she had a category 2, but you easily delivered the head, and then really you did the
Mhm.
standard maneuvers that 95% of shoulder dystocias will be um, relieved with those 3.
Yeah, I
It
mean
would,
the the category 2 tracing may have uh, been progressing to category 3 during that second stage, and that's the reason that I could, presume that the APGARs were poor. But when I was called to the delivery room, I recognized that the tracing was not reassuring and made that immediate decision to um, assess if the patient was a candidate for a vaginal delivery, and then proceeded with that.
So basically, while the patient was, if I'm hearing you correctly, while the patient was pushing, there was a category 2 tracing. And then as the
Mm-hmm.
patient um, eh, progressed further, was that labor and delivery called you and said, okay, or were you going in and checking? I guess what I'm trying to figure out is, you said you went back into the labor room and you looked over at the tracing and you weren't happy with what you saw and you got the vacuum and got the head delivered. Is that correct?
Yes.
So seriously, Maddie, I'm going to go out of examiner mode for a minute because
Uh-huh.
part of this is also to just kind of help you guys talk through this. If you look
Yeah.
back at that tracing, would you think the labor and delivery nurse undercalled or missed the
Yes.
severity of the tracing?
Yes, I think that this may have been where there was a loss of situational awareness, why the patient was pushing. She progressed to complete really quickly, and then pushed for maybe an hour and a half, and in that time, I think
Hmm.
the tracing got progressively worse, and I unfortunately I was seeing patients at my office, which is what we routinely do. We have
Sure.
an OB hospitalist that's at our practice, and so you presume that you've got multiple people that are watching that tracing. And I really truly feel like I was not um, notified, soon enough, or maybe there was some of that loss of
Right.
situational awareness among the nurses because the patient was pushing, and you're anticipating the baby is going to be there soon.
Right. And that would make more sense to me. And I could see the examiner maybe asking you, like, this is impossible. How can you go from a category 2 tracing where
Hmm.
you deliver the head easily, you do 3 maneuvers, the
Yeah,
baby comes out, the shoulder dystocia, and there's a 0, 0. And so I
right.
think and so just be prepared that, in your assessment, going back and analyzing where did, how we always look at systems, how did the
Hmm.
system fail? We're
Yeah,
never supposed to blame it on a person, but there was a failure in
right.
the system here. And so it started with the
Yes.
L&D nurse not paying attention enough of the severity of the tracing and not accessing
Hmm.
the OB hospitalist who's right there, that they could have come in,
Right.
taken a look and jumped in and did it. You weren't even in the hospital.
Yeah.
You're seeing patients assuming that the system was working. So you came
Hmm.
in. All I'm saying is, so I don't want you to feel, um, I just want you to be comfortable explaining how you think the system failed. Now, did
Okay.
did they do an M&M on this or anything, like, and try to evaluate
I
where did it
Yeah, I
break
mean,
down and what do we need to do different?
right. We are not an academic. We're institution. We're kind of community hospital, so we don't
Hmm.
have like a formal M&M presentation like
Hmm.
I recall having in residency. But I did speak with risk management and the chair of OB-GYN department and the nurse manager regarding this case right after it happened,
Okay.
because it
And
was difficult for me too. Yeah.
oh, I'm sure it was very traumatizing. Anyway, so you get the baby. Do you
Mhm.
have any idea what the 10-minute APGAR was?
It was also very low.
Okay, because what they usually recommend on the case list, so you might want to know that before you go take the exam, because if you have a 5-minute APGAR that is less than
I
6, they would like,
I
go ahead.
I it may have been 0 still at 10, but they did get a heartbeat back
Okay,
after that.
okay.
This baby is still alive, but did have to do cooling, and may have sadly has consequences from this.
Yeah, so then you wonder what deteriorated so bad. I mean, yes, she has a
Hmm.
marginal infarct, but it wasn't like it was a complete
I
abruption. You know what I
know.
mean?
I
Something's not,
know.
yeah, something doesn't add up here. But so if
Hmm.
they asked you about this, which I bet you they will, the 0, 0. So what could they ask
Yeah.
you about? The marijuana use, which you did a great job with. Okay, perfect. Class 3 obesity. I think I'm going to find one of the other candidates, and we'll go through the class 3 obesity. I'm going to show you how you can maybe structure it a little bit different, but that is an important part
Okay.
of this, but not the biggest part of this. But the biggest thing, of course, would be
Okay.
in addition to abnormal fetal tracings, what are other indications for operative vaginal delivery?
Um, Another indication could be maternal exhaustion.
Okay,
Um,
and I
I think
see
those
here
are the
that
two biggest reasons.
it really is. It's maternal reasons or fetal reasons. The fetal reason would be, of
Hmm.
course, abnormal tracing. The mom would be exhaustion, and what
I
else?
guess
And
another reason could be like if a mother, another maternal reason, if a mother had like a cardiac um, problem and you wanted to decrease, her efforts with pushing.
perfect. That's exactly right. I was expecting you to tell me it was like some gruesome, horrible shoulder dystocia, that the baby was
Hmm.
stuck for 20 minutes. That's what I'm
Right.
expecting. And I'm like, okay,
Yeah.
so that really, so anyway, so you know the indications
Yeah.
with I see you're one of the few who actually does forceps. I'd say you're in the maybe 5% of case lists I review. Does anybody even have a forceps?
Hmm.
So again, be prepared to discuss why you chose a vacuum versus a forceps for this patient. How would you,
Okay.
what would be your reasoning? Go ahead and tell us.
Um, I mean, I think in this situation that so I mean, she was obviously she met all the standards for an operative delivery, which we could go through. She was complete. She was they would have been outlet. Um, the head presentation was like slightly asynclitic, which I think made applying
Mhm,
the vacuum um, easier than trying
mhm.
to do forceps.
Okay,
And then also at our hospital, it's much quicker to get the vacuum
it,
available.
good. It shows good thought process. And again, for you, most of the other candidates just have vacuum, but then you'll be able to discuss why you would choose one over the other. And I think that's great. Um, Yeah, and so then the other thing we talked about the obesity, the tracing, the shoulder dystocia, you did that perfect. And then of course the big question would be what they're going to ask you why were the APGARs this? And so I want you to feel
Okay.
comfortable with what you think happened and what you did
Yeah.
afterwards, like talking to the risk management. You
Okay.
went back, you reviewed the tracing, and to
Yeah.
you feel there was a system failure of that you should have been notified much sooner. You had not been, and
Hmm.
they did not access the hospital list. And I
Yeah.
think that would be a good
And
way
so
to.
you think that's okay? I mean, that's the truth, which I know they want us. I mean, we should
Yeah,
be
and that is, I mean,
honest, but it's just,
here's the thing. This is real life.
yeah.
If we never saw patients in the office, and as soon as a patient came into labor, we sat in the labor and delivery room and watched the tracing the entire time, then why do we have labor and delivery nurses? I mean, I hate to say it.
Right.
There was a
No,
person
I
there who
know.
was trained. Okay,
Hmm.
tell me why you're getting queasy with this.
Uh,
You're not
just,
throwing
just
anyone under
because,
the bus. Go ahead.
yeah, yeah. It was just a hard after the fact. You're just always like, what could you have done different? Why did this happen?
100%.
Going
And you
back and
should,
looking at
and
the tracing, you're like, we look at bad. You sometimes will watch a tracing where you're worried about a baby and then you deliver them and have 9 apgars.
right.
So it's
Yeah.
just,
Yeah.
uh,
And I think
it
that you
was
can
just kind
be
of a
very
devastating thing to go through. Yeah.
yeah. And if they ask you, you should say that, this case haunted me. This was
Okay.
devastating for me. And that's being very honest. And then just you can explain what happened, how it happened, what you did afterwards. You felt it was a system failure. You went to risk management, blah, 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 blah.
Okay.
All right.
Okay.
Okay,
Okay,
all right.
cool. Thank
Hey,
you for
Maddie,
going through that with me. It's been a tough one on my mind since that
I'm sure.
delivery. So,
Where, where in Oklahoma do you practice?
I'm in Norman.
Okay, this is so funny. Okay, sorry, you guys, I got to go off. My daughter just got a teaching job at OU. So this is her first year as an
Oh
assistant
my gosh!
professor. She has her
No
PhD and
way!
she's in Norman right now. So there you
Whoa, what
go.
a small world!
I know.
That's
I'll have to find out.
crazy.
I know she told me just today she made her GYN appointment. She's seeing somebody in December. So I'm gonna have to check and find out if it's you.
That would be pretty crazy.
But anyway, nice to meet you. She loves
Yeah,
Norman,
you
by the way,
too.
just so you
Thank
know.
you. Yeah, it's a great little place.
Yep, that's what she says. All right, thanks, Maddie. All right, so let's see here. Paula. Hey, Paula.
Hi,
How are you doing?
I'm doing fine, thank you. How are you?
Good. Are you a general OBGYN?
Yes, I am.
All right, I'm gonna go to the OB. Do you have a I should back up. Do you have a particular case or case list that you want to cover?
I was thinking gynecology, but since you're already in
Okay.
the OB list, I'm fine with that too. But you can just pick whichever case.
Did you have a particular GYN? Because I can jump out. I really can. It takes no time.
No, I don't have a particular case. I just kind of wanted to be surprised by the question.
Okay, got ya. Gotcha. Well, you know what? Let's just do that. Let's just surprise you with your GYN. And you Urogyn?
No, I'm a generalist.
You're a generalist, but you're doing incontinence and pelvic prolapse cases, correct?
I do. I just do. I'm actually being proctored to start doing uterosacral ligament suspensions myself. So all the suspensions were done by a colleague, but I do the slings myself.
Okay, gotcha. All right, let's do patient number 23. So you had a 40-year-old who was diabetic, who had, I'm guessing, symptomatic pelvic prolapse as well as stress urinary incontinence. So I want a couple of different things. Tell me how you evaluated the degree of her prolapse and what type of symptoms was she having. And then I want you to tell me how you evaluated her incontinence.
Sure. So when I am evaluating the severity of prolapse, I start out by talking to the patient and figuring out what is bothering them the most. In this particular patient, she was having to splint in order to have a bowel movement. And she was also just feeling pelvic pressure and a little bit of dyspareunia as well. And after talking to the patient, I will do a physical exam, and the most important part of that being the POPQ, where I will assess the degree of the prolapse from the anterior and the posterior compartment, and then also the apex as well. Was there a second part to the question? I'm
Yeah,
sorry.
and then tell me how you evaluated her incontinence. How did you come with the diagnosis that she basically had uncomplicated SUI?
Sure. And so the patient did mention that she was having leaking of urine with coughing and activity. She denied any symptoms suggestive of your urge incontinence or overactive bladder. During the physical exam, I also did a cough stress test, and then I will also perform a post-void residual to sort of exclude the fact or exclude the possibility that the patient's having leaking as a result of retention. And then I'll also send off a UA and a urine culture as well to exclude infection.
Okay. So you did the a UA urine culture, you documented leakage with the cough test. Do you
I'm sorry, I lost you all. I didn't hear anything after you mentioned that, sort of like reviewed what I did. I'm still here, by the way. I'm just waiting for you to come back. I can't hear you.